Well, welcome everyone. It's the fourth or fifth session in a series that focuses on embodiment. And this is one of the series that's put on by the 2022 to 24 leading scholars. And so by definition, it's interdisciplinary and it's been a great success. I'm just going to, apart from welcoming you, again, I know most people here, but if you are new to the college, do come and see us again. And I'm going to hand over to Jasmine, who is going to take over.
Well, thank you all for joining today, and thank you all who are also joining online. Before we get started, I do just want to acknowledge that we are located here on the traditional, ancestral, and unceded territory of the Musqueam people. And I know for myself, I grew up in Ontario, and Ontario is beautiful, but I got to say, I was pretty quick to say, I'm sorry, Mom, I'm not coming back when I moved out here. So we are just so fortunate to get to share in this land, to live, work, and play here. So I did want to say a little bit about Paul before we get started, because, Paul, I'm just so excited for you to be here. So our theme is embodiment as knowledge translation. And I got to say, when I was learning about Paul, I learned a lot about geography. So Paul is Canadian, well, despite being in the States now. I shouldn't say despite. I'm very happy to have you still in North America. But he's been all over. He did start much of his training at the University of Calgary and then transitioned over to the University of Western for his PhD, where he did some work in group dynamics and physical activity. His first faculty job was at Kansas State University, where him and a team of partners scaled the Walk Kansas initiative, and this is really, really incredible. Their initiative increased physical activity for over 70,000 residents in its first 5 years of implementation. So you can see here, Paul does big work. During that time and since, he has been pivotal in the development of the National REAIM framework, and I won't do the whole REAIM and its constituents justice. So I encourage you to Google reaim.org, this whole website. But just as an example, the REAIM framework is one of the most widely used frameworks for the equitable translation of science into practice, both nationally and internationally. Since then, he's made his mark in many other institutions, for one at the Kaiser Permanente Clinical Research Unit in Denver, at Virginia Tech, at the University of Nebraska Medical Center. See what I'm saying? Like, I was learning so much geography. And to where he now calls home as a professor of health and kinesiology and associate dean for community engagement in the College of Health at the University of Utah. So overall, Paul's work has had and continues to have tremendous large-scale impact in physical activity, healthful eating, diabetes prevention, and weight management interventions focused on resolving health inequities. Moreover, beyond the national and international impact he's had in dissemination and implementation science, honestly, when you talk to Paul, you pick up instantly. He's a people person. He really cares about the individual and someone who really connects. His colleagues, when you talk about Paul, they very much hold him in high regard, both for his collegiality as well as his mentorship. And his passion and excitement really, truly for your work shines. He's here to listen intently and thoughtfully, put knowledge into practice, and to help support the diverse embodiment of health behaviors. So with that, I'd like to welcome Dr. Paul Estabrooks.
All right, well, thank you. That was a very nice, warm introduction. So, and it's a pleasure to be here. You can read my title up there. I put a lot of words into it, so you can take your time. I'm not going to say it out loud, but I'm going to get into this talk. And as I get into the talk, one of the things that I do like to do is have interchange during the talk, so you don't have to wait till the end. If you have a question, raise your hand, and I'll be honest, if I'm going to get to it in a little while, I'll tell you, I'm going to get to it in a little while. But if I'm not, we can talk about it right then. I did want to just really thank Jasmine for the invitation here. I'm not sure if you can see the sign up there. This morning I got up and I went for a nice walk, and I found these stairs that went all the way down to the beach, and I thought, this is great, I can get my stairs in for the day. And then as I was walking back up the stairs, I noticed this sign, and I don't know if you guys can read the details on the sign there. I can't read it on my screen because it's too small, but I didn't realize initially that it said Rec Beach clothing optional. And so that surprised me a little bit. I did want to let you know I optioned for clothes, just so that, I did do that. But in more seriousness, and I know that Jasmine's already done the land acknowledgement for you all here at Green College. I really appreciate being invited here and to be able to learn and hear about the stories of this land at the University of Utah. We are also on traditional lands that are for the Shoshone, Paiute, Goshute, and Ute tribes. You can see that we also respect the sovereignty of those nations, and we have at the University of Utah a really special connection and collaboration, in particular with the Ute tribe, and have really nice programs that bi-directionally help us to learn about the heritage and the history of our Indigenous partners, but then also giving opportunities for Indigenous families and children to be educated at the University of Utah. All right. So you heard Jasmine talk a little bit about something that I do, which is dissemination and implementation science. How many people have heard that term before? Okay, great. How many people have heard the term knowledge mobilization? A few more people. So when I am in the United States, which is where I've been for the last 25 years, we talk about the movement of evidence into action and the study of the process by which that evidence moves into action, dissemination, and implementation science. And so I've provided you here with the definition. And this is, again, this idea of embodiment was new to me when Jasmine invited me. So I kind of thought, well, what does that mean, to me? And so you can see what the study of dissemination and implementation science is based on a definition. But to me, one of the things that I learned very early in my career was that I was really interested in science. I am a sciencey person. I like to learn new things. I like to be able to rule out alternative reasons for why something may or may not happen. But at the same time, I'm also very interested in having community impact. And so for me, the type of research that we do when we do dissemination and implementation science is we have what we call our dual aim. One is that it's moving science forward so that we can learn things to help other communities benefit from the work that we do and share that. But we also have an aim that we have an impact in the communities we work with while we're doing the work. So our designs are a little bit different in terms of we typically don't randomly assign a group of people to no intervention or a wait list control. We typically are doing things that might be comparative effectiveness trials where we have 2 active interventions where everyone gets the opportunity to benefit. Or we might try different types of research methodologies and designs that don't require people to not have an opportunity to engage and benefit. So when I think about dissemination and implementation science, I really think a lot about 4 words in particular, and that's context, strategies, mechanisms, and outcomes. And I'll talk a little bit about those as we go through. With Jasmine's introduction, she talked about the RE-AIM framework. And so if you did want to go to it, I should have it up on here too, www.re-aim.org. We've got a really nice website that gives you a lot of different ways to engage with this framework. But what it does is it gives us a set of outcomes. It moves us beyond kind of traditional science where we're trying to see if something works to improve physical activity or it works to improve health, to moving beyond that. We want to do that, but we also want to know, well, how can we make sure that we reach a whole bunch of people with it, and that the people that we reach with it include those people that typically don't get reached by these types of interventions or underserved audiences. Effectiveness, obviously, we want to understand, but we also want to understand the degree to which our programs or policies can be adopted by typical communities, right? So we're not designing things that can't be used readily, and again, hopefully in communities that typically don't have access to these types of programs. Then we also want to study the process by which we implement these interventions with some level of fidelity so that we make sure when we translate things that work in the scientific realm into the community realm that they still work, that we still get that same type of outcome. And then finally, how do we study and design things that can actually be sustained or maintained in community or clinical settings. And so when I talk about dissemination implementation science, remember we talk about context, strategy, mechanisms, outcomes. These are the outcomes that I think about. These are the outcomes that I work on almost across all of the projects that we do. And then when we talk about inequities, we know there's a lot of populations that have experienced, I was going to say in particular in the United States, but I think it happens all over the place, where there are policies and systems in place that that systematically give some people less opportunity than others. And so when we think about designing, say, things like for diabetes prevention, I had some slides in here a little on a project that we're doing right now, and it just didn't quite fit, but I'll just touch on it here, where we're doing some adaptation of a diabetes prevention program for Hispanic Latino audiences. And for those who don't know, in the United States, we have the National Diabetes Prevention Program, which is an evidence-based approach to help people eat better, be more active, lose a little bit of weight, but then also delay the onset of diabetes or prevent diabetes completely. And so with this National Diabetes Prevention Program, we have an English version and we have a Spanish language version. And when they looked at across all the data for people that had participated in this over, I think it was about an 8-year period, what they found was that people from Hispanic and Latino backgrounds that participated, about 18% of them lost the amount of weight that would be necessary to delay the onset of diabetes. When we looked at overall and compared them to the white participants that have gone through it, about 28% of white participants. So that's a big gap, right? And so if we're taking a program like that to scale across the United States, we're actually going to make the disparities worse, right? Because we have a program that works okay for them, but not as well for others. And so and then when we looked at the Spanish-speaking diabetes prevention, it actually only popped up by maybe another 3 or 4%. And so one of the projects that we're working on right now is kind of doing a deep dive with the community to say, well, what is it about this program that we need to change that makes it more culturally specific, more linguistically relevant, and actually meets the needs of the community, so that we can design a program that actually works better than what the National Diabetes Prevention Program is working for our majority population. And so I give you that whole little lead in, and this is why I like you guys to ask questions, because I will go off on tangents like you don't believe. But when we look at this differential across REAIM outcomes, that really is oftentimes we're looking for differential outcomes. We want to reach more of the people that experience disparities. We want to be more effective in those populations. We want to have interventions that can be adopted more readily in under-resourced communities. So it's really about this differential approach and really thinking about how we can address disparities and hopefully resolve inequities. The next thing, I'll kind of tie these two things together, and don't worry, I'm not going to walk through all of this. This is the practical, robust implementation and sustainability model, and it provides kind of context and mechanisms by which, if we want to change those outcomes, we have to know what the context is that we're trying to change them in. And so you can see up on the slide here, it talks about contextual factors like an implementation and sustainability infrastructure. So that can be about the things that are in a community from a social ecological perspective, everything from policies to built environment to programming. And it can also be external environmental factors. So if we're doing something like a diabetes prevention program, there's differential ways that participants can engage in those and have the burden of cost removed based upon insurance and those types of things. But those policies, again, sometimes have an external influence that reduces participation because people that don't have the resources to be able to pay for that type of programming can't actually get the insurance coverage to do it. And then when we think about kind of in the middle there, we have people. And so I think this is where I start to think about the embodiment stuff that you guys talk about. Like, there's people within organizations that would adopt, implement, and maintain evidence-based interventions. And then there's people that would receive those and benefit from them. And so the characteristics of the populations on both of those groups, as well as their perceptions, can provide us with targets for our implementation strategies to improve things like reach, adoption, implementation, and maintenance of evidence-based interventions. Okay, and I wanted to just kind of highlight each of these here. Remember I talked about context, strategies, mechanisms, and outcomes. I kind of finished with strategies here because this is what we're going to do a little bit deeper dive on. I'm sure I could put everyone to sleep because I have talks on each one of those things for the context, one for mechanism, strategies, and outcomes. But we're going to talk about strategies mostly today. And the strategy that I've used most consistently across my career, we've labeled as integrated research practice partnerships. And so that's a bit of a mouthful, but basically what it means is that as a scientist, I have a pretty good sense of what we know around behavior change science, right? I know what we've found, I know the literature, I can understand types of things that have been done previously, where they may apply and where they won't apply. But then if I try and design things that are intended for a community or a population that I am not of, the likelihood that I'm going to design something that's relevant for that system, those people, is pretty low. And so this integrated research practice partnership is just kind of a science-y name to say, we want to make sure we get together with the people who are going to deliver the interventions that we develop or the programs that we develop and figure out a way that we design these things that they can use and that can also benefit the people that they serve. And so we're going to go through this. You can see there's a full process model down the middle of this, but really the two sides of circles are intended to reflect scientific evidence and then kind of practice or community evidence. And knowing, I always love when, I hear people talking about indigenous research methodologies, and the term of multiple ways of knowing always resonates really strongly with me, because it's not just scientific evidence, right? There's all this other lived experience evidence that we have out there, that if you match those two things together, the likelihood that you're going to create something that's effective, reaches the population, can be broadly adopted, implemented, and sustained, it's much higher than if you're just trying to do it as a scientist on your own. Okay, so one of the things that I wanted to kind of walk through it when we do these integrated research practice partnerships is we typically have a fairly set structure of who's involved, although who actually is involved varies quite a bit from project to project. And so you can see here we have typically there's folks on my side, an interdisciplinary research team, and so sometimes I get asked by researchers, well, why isn't it just you? Why don't you just do that part? And again, we all need to bring our humility to the table and know that I know a good bit of stuff around dissemination implementation science, physical activity promotion, healthy eating, and weight control. I don't know much about workflow analysis. I don't know much about costing and understanding cost benefit and return on investment. And so when I pull together teams that we're doing these partnerships on, usually that interdisciplinary team has at least two people in addition to me. So it's usually me, and then it's somebody that's a health economist, so they can do kind of the costing stuff and understand that. And then I also usually try and get a systems scientist involved in that too. So they're the people that can understand workflow, who does what, where, when, and how. And then we then have kind of this next grouping. I kind of separate the other two circles at the bottom into easier words than I have up there: decision makers and doers. So when we're working with a system that we think might be one that would prioritize physical activity promotion, we want to get in the room the people that can make decisions about what that system or organization or community will do. And we also want to get in the room the people that would do it, right? And so then you get kind of practicality from the people that would do it. And then you make sure that you're designing things that are aligned with institutional priorities and decision making. And so that's really the idea. So we have community system administrators, and then we have interprofessional implementation staff. And again, kind of just dependent upon which type of intervention that we're building. Okay, so, and you can see what these folks do. We really start from this idea of prioritization. And if somebody wants to ask, how do you kind of match up on this stuff, I can ask that question at the end, because I can tell you a little bit more about how you initiate these types of partnerships. But it really does focus on prioritization, not only of, hey, let's pick up this physical activity program, but then also prioritization of the strategies that we're going to use to get that program into action in whatever system we're working with. And then it also makes decisions about the project designs, the outcomes that are important, and then information that you might need for sustainability or scalability. Okay, so the early conceptualization of this, again, Jasmine did a great job talking about Walk Kansas, which was something I started in like 2000. So that's a long time ago. This is when you start to realize, gosh, I'm really old. I had just another tangent here. Earlier today, my master's degree supervisor gave a talk at another place on UBC campus, and we hadn't seen each other for about 8 years, and so that was kind of fun to get together. But anyway, this is back in 2000 working on Walk Kansas, and what we really did is, as Jasmine said, I came out of University of Western Ontario, and I had really focused on health psychology, and in particular, group dynamics and how that could help older adults become more physically active and then maintain that physical activity. Okay, so we designed kind of interventions that people would meet together 3 to 5 times a week for somewhere between 8 and 12 weeks. And we showed that if you use group dynamic strategies, you get much better adherence to the program. You get people to come back after there's a hiatus in the program. So really much more effective than just, kind of a standard exercise class that people would go to. And so I kind of brought to this partnership all the knowledge around group dynamics-based physical activity promotion. And then I partnered with a system in the United States that's called cooperative extension. And for those who haven't heard of that, it's associated with what's called land-grant institutions in the United States. So in about 1890, the federal government granted land to each state in the United States and said, on this land, we want you to put an educational institution. In that educational institution, we want you to do agricultural research. And with that agricultural research, we want you to have a system by which you can get that agricultural research out to the farmers, and so that they can actually improve what they're doing. So it was really, I think, in my view, probably the earliest knowledge mobilization system or dissemination and implementation system that partnered with academic institutions to try and make an impact in communities. And so within cooperative extension, one area they focus on is family and consumer sciences. And so I partnered with the person that led that group, and they were really interested in doing some physical activity promotion. And so I will again say, anybody that's doing knowledge mobilization or implementation science, the one thing that you always are looking for, the holy grail, is when there's a pull from the community or the system, and you're not there trying to push your ideas to them, right? They want to do this. So that's a big part of it. So we worked together, and we designed Walk Kansas, which took kind of some of the research I'd done as a doctoral student and other people's research, and we redesigned the intervention completely. So it was one that, rather than us making people come to one place and do their exercise together, we thought, well, we really are focused on rural areas where we know there's disparities in physical activity. And so we need to come up with a way that maybe we could recruit not just individuals, but we could recruit social networks. So like family groups, work groups that would join in 5 or 6 people, and then they would set a collective goal to walk across the distance of Kansas. They didn't have to actually walk across Kansas, but we would count like 15 minutes of walking would be 1 mile, and then they would report those mileage to their team captain, who would report it to a cooperative extension health educator at the county level, and then that educator would send out our weekly newsletter. This is how old it is. Our weekly mailed the weekly newsletters out that showed where each team was, how they were making progress, and that kind of thing. And so by doing that, we kind of made a whole new structure of the intervention. So it no longer made people come together, but it still used all of those group dynamics principles of goal setting together, of peer problem solving, of reporting back and having accountability to a group of people. And so with that intervention, we used the RE-AIM framework to determine, did it work? And so I'm not sure how well you can see this slide up on the screen. It looks a little small on my screen, but what you can see is when we did the first year of Walk Kansas, we did an evaluation, and we separated people into those who joined the program when they were already active, so they were meeting recommendations for physical activity, those who were insufficiently active, that's that kind of lighter blue color in the middle there, and then people that were inactive. And the people that were inactive are the darker blue, and you can see at baseline that means they were doing no physical activity, right? And so what we did is we looked at not just did this program increase physical activity at the end of the program. The data that you see on the left-hand side of the screen there for you is 6 months after the program is done. So this and what you can see is that we increased physical activity significantly, and to a greater extent than a lot of the earlier interventions that we developed before. And so part of that improved effectiveness we attribute to the partnership that we had with Cooperative Extension health educators and people that could make decisions over those programs to come up with what the design and the structure of the intervention would be. And then by taking the science and kind of mapping that on top of that, we ended up benefiting from both worlds of knowledge. So then, as Jasmine also said, we had a lot of success with REACH. So in our first year, we had 6,000 people participate, primarily in rural areas of Kansas. And by the last year that we did the evaluation, you can see that we were up to about 20,000 people a year that were participating in the program. In terms of adoption and sustainability, this next graph shows you basically what it tells you is that about 50% of the agents or the health educators across Kansas adopted Walk Kansas the first year. And then if you look across that solid dark bar across the bottom, once a county or a health educator started delivering the program, they sustained it. So they did it on an annual basis thereafter. And then you see each kind of addition is new counties that came on board. And so by the 5th year, we had 95% of the counties in Kansas delivering the program. The only ones that weren't were counties that didn't have a health educator employed. So we had complete saturation across the state in delivery of the program. And again, as you can see, as soon as a community began delivering it, they sustained it thereafter. And you know, we've never written up anything after this initial data. But what I can tell you is right up until COVID, Walk Kansas was being delivered within Cooperative Extension and reaching somewhere between 20 and 25,000 people a year. And so that's like, you know, that's 20 years worth of time where this is going on. And I would also point out that, as Jasmine said, you know, I'm not a problematic person. I didn't move around because I was problematic, but but I did leave Kansas State University in 2002. And so if you look at the data here, you know, our last data of the study was 2006. And so it sustained. So it was really not about me. I had a component to it, I had a part in it, but the way that we designed the program to be integrated within that practice system is what led to, I think, both its effectiveness and then the sustainability of the program. And in fact, the core group of people that worked on it, and I think there was 5 of us that, not I think, there was 5 of us that worked on it, only one of them was there up until COVID. And so really, it really was this idea that, hey, if we build this thing together, focusing not just on the science of how we increase physical activity, but also on what our practice partners tell us about how we might design this to fit best in the system, we can end up with something that's sustained for a very long time, reaches a lot of people, and effectively promotes physical activity. Oh, I don't know what happened there. Okay, so the other thing that when Jasmine and I talked about this talk was about how decisions are made. And so one of the things I wanted to point out here is, you know, who made decisions around the Walk Kansas process? And so when you look up here, you can see that the design and outcomes. So I didn't tell you a whole lot about the design, but it was basically a demonstration project. Pre-test, post-test, no comparison group. This is what we did. We're doing a good evaluation of it. The outcome was physical activity. And so when we think about that design and outcomes, the decision was made collaboratively about what the design would be, so both the research team and the practice team. But the outcomes were focused really heavily on practice. What are the things that will help you in your organization be evaluated well and be able to promote this as a program that should be sustained? And so when we came up with using the REAIM framework, a lot of that was because cooperative extension looked at impact in the annual evaluations of health educators. And the way they defined impact was reach, right? And so by us having a program that reached 6,000 people in the first year, it was the highest reaching program that they had had. And so that's why in the second year we got almost all the other health educators to start picking up on it. The other thing that we did in this decision-making process was we talked about, well, what would help the decision makers in the system be able to make the case to sustain a program like this? And one of the things they said is, well, in our annual reports, we have 3 different things that we need to talk about: what the gap is that we're filling, what our impact was, and how our constituents appreciated the program. And so what we created for them during the process was an annual report template. And it was very simple. They could just take exactly that template, put it right in their annual report, and then we, as the research team, also committed to providing the data feedback. Now that transitioned after our 3rd year into the system itself because they wanted control of the data, which is completely appropriate. But that also helped to make the decision about what's the data that we're collecting. But then when you get to things like, the adaptation of the program, again, that was kind of this shared decision making, right? We don't want to adapt a program without understanding the science that underlies why it works, right? If we do that, then we run the risk of making adaptations that make the program ineffective. Right? But at the same time, we don't want to be so rigid on the science side that people can't change how many times people come, how many sessions you have, and those types of things. But then, I think where the kind of exciting thing to me about doing integrated research practice partnerships is that's kind of where my decision making or the research team's decision making really ends. Right? Everything after that about adoption, implementation, and sustainability is up to the system. And so understanding that really helps us to design studies that we know that we're meeting the needs of those groups. Okay, so I'm going to change direction a little bit here. I wanted to give you a flavor of some different methods that we've used. This is a project that's ongoing right now, and I'm going to walk through it. I'll tell you first of all that it's something that we're doing with the University of Utah Health, which is one of the largest healthcare providers in the state of Utah. And you can see our partnership that we have here is we have interdisciplinary health and wellness researchers, including myself. And then we have the health system, wellness, and integrative health leadership. So everybody that's interested in lifestyle, behavior change types of things. And then the health system providers who want to connect their patients with available resources. And then their patients who would like to be connected with those resources. And in this particular project, we had 2 clinical partners, both of which primarily served Medicaid receiving patients, which for those who don't know, which probably is most because I'm in Canada and not the United States, that's our lower income audience that basically has federal insurance. Okay, and so in this particular thing, we kind of had this need that was identified both by patients and providers. And that's that, I don't know if you can read the little things up there, but within Utah Health, we have 12 different programs that can support lifestyle behavior change. And there's a couple of things that are problematic with that. One is that which one is right for me as a patient? The second is, as a provider, how am I supposed to remember 12 different programs when I'm also providing primary care on a whole bunch of other things that a patient would come into? And then the other issue here is that none of these are populated to capacity, right? So they're not reaching, even though you have these things available. People aren't taking advantage of them, and in particular, people from the clinics that we were working with. And so we used another methodology. And so if folks have has anyone ever heard of comprehensive participatory planning and evaluation? Okay, great. So I'm bringing something new to folks. So this particular methodology is kind of, it's kind of mixture between community-based participatory research and just kind of deep qualitative engagement with your intended audience, right? So it's kind of a mix of those two things. And what it usually has is 3 components to it, and at least in this project, I'm going to tell you about the 3 components. The first is to create maps with the constituents, the key partners who are being influenced by the issue. So in our case, why aren't our lifestyle programs reaching the populations that could most benefit from them, right? That's our basic question. And so we start with a meeting with patients who could benefit from these programs, and we just ask them that question. And then they start to come up with all the different barriers to participation, as well as things that might facilitate participation, and then they create maps. They kind of create a big map and say, this is how I think you could get to better participation. So once you've done the map, then we end up coming back. We, as the research team, take the map away. We kind of clean it up for them, present it back, and say, did we get it right? Right? And then we also, at that point, this is where our integration of research and practice comes back together. We overlay what do we know scientifically about strategies that can address the barriers we've identified, as well as strategies that might be able to leverage the facilitators that you've identified. And then the third meeting that we have is really looking at a toolkit on how we might operationalize this type of work. And so again, remember I had my concentric circles of kind of practice-based evidence and research-based evidence. We kind of have that here too, where while we're doing all of this stuff, and I also didn't tell you that we had 3 collaborative group meetings with providers, so people that were physicians, physician aides, people that worked in those primary care clinics, and then we had 3 collaborative groups with patients. And then we tried to merge those things together. And we kept them separate just so that we didn't have kind of power distribution and imbalances amongst the groups, and we could really get clear feedback from each group. And then at the same time, we did a scoping review of the literature to try and find out what is available to help us improve strategies to get these programs to reach more people. And so I'm not going to spend a ton of time on this because I can tell that I'm going to be long already, and nobody's asked any questions. At least nobody's sleeping yet, so that's good. So this is our patient causal map, and so again, I'm not going to go through it in detail, but you can basically see up here there's kind of generalized areas like the things about accessibility, the programs, what do they cost, am I eligible for them? If I'm eligible for them, would Medicaid cover it? Would it not cover it? So a lot of those accessibility issues, program characteristics, is it really long? Is it intensive? How do I get there? Where is it? All those types of things. Personal factors, do I really want to make a change? How do I fit it into my work schedule and all that kind of stuff? And all of those things can lead to the reach of these types of programs. Then you can see down the middle, they started talking about strategies or things that they would value, so facilitators that would either help to get them there or once they were there would help them stick with it. And so, again, I don't want to go into a ton of detail, but I did want to show you the difference. I'm just going to kind of flip back and forth. So there's the patient causal map, and there's the provider one. And if you look kind of closely at the two, you'll see that the 3 big buckets on here, accessibility, program characteristics, and personal factors, those are all on this one too. But they have this other one, this referral factor, that was a big issue. And that issue includes there's 12 programs. How do I know which patient is supposed to go to, which one they benefit from most? Is there any automated way? Do we have a smart sheet or a goal that can help me to push a participant to the right thing? A lot of things around just a lack of clarity. How do I get the right person to the right lifestyle program at the right time? And so we take both of these maps back to our groups, and then what we did is we found 2 different interventions. We actually found 5 different intervention strategies that we then reviewed with the group in the second collaborative group meetings. And the 2 that they really liked was a population health management strategy that had been used elsewhere, and I'm going to kind of walk through that. And that was that it starts with using technology to review the electronic health record and identify people based upon the eligibility characteristics that they have that match a given program that would be available for them. So we kind of take that decision-making and memory needed away from the providers, right? And this was something that providers really liked, and patients really liked this too, because they felt like, hey, great, I'm going to get identified. I don't have to wait to go into the office and make an appointment and all those types of things. And so then once we had eligible patients identified, we ran into this issue where there was this really, really interesting thing where this is almost a direct quote. I'd really love it if my provider could just kind of sit down with me and talk me through this stuff, right? So who did that come from? The patient group. And then we get another quote that is almost the exact, well, no, it's not even close to the exact same thing. The other one comes in and says, I am so tired. I just don't have time to be able to talk to my patients about this thing. Do you have any way that I don't have to talk to my patients? So these two things, so there's this kind of juxtaposition, right, where the system is such that here's what a patient would love. And let me tell you, our providers they're not inhuman people. They want to work with folks, but this is one thing on a host of things that they need to do when someone comes in for a visit. And we could have a whole nother talk on health systems and issues related to that. But so we ended up with this one thing that came from the providers, where some of our providers, we almost came up with phenotypes. One group that wanted to be, let me see which of my patients are going to be eligible for which program. Then I want us to send out a message to them from me that will say, join it. I do want it to be automated, but I want to oversee it, and be engaged in it. Then we had another phenotype that was, I'm tired. I have so many patients. I'd be happy for you to reach out for them on my behalf and just take me out of the loop. And then we had kind of an in-between group that, we had the one that really wanted to be engaged, and then we had the in-between group that wanted to review things but not do a whole lot of engagement, right? And so we created this. So you have one that could review the list, or you could have one that doesn't review the list and something still goes out with their name on it because they believe in what we're doing, or something goes out with the chief wellness officer name on it because they just want to be out of the loop and don't want anybody following up with them. And so from there, we talked about how do we best communicate. And so from our patient group, they were really pretty open to any type of communication. And so you can see here, you could have mail things, you could have email things, you could have text messaging, and the text messaging would be included with the patient portal. And so I'm not sure if you guys use patient portals up here, but it's basically a place where, okay, great. Someone's nodding and saying, don't be an idiot. Of course we have patient portals. So they could get it that way as well. But the idea was that there would be options. Those options are already indicated in the electronic health record. So that's something we wouldn't need to do. So it would already be based on patient preference on how they wanted to be contacted. And then the next thing that we had was we knew from this population health management approach that proactive follow-up. Right, so sending someone a message, a text message, a letter, or an email, we know that the likelihood of them following up on that is much better if someone follows up with them right away afterwards, right? And so, again, this is something that we had to design. We had to make two different pathways. Some patients didn't want you to do that, right? And so if they don't want to do that, then they don't get any active follow-up. If they say active follow-up is okay, then we have different ways that we can follow up with them, either through the patient portal or through telephone, which is what they liked. And then we came up with a thing that we found when we were working with our patients, that they're like, oh, I think I'm eligible for 6 of these programs. You're like, okay, great. So now we know you're eligible for 6 of these programs. You could get down to this part and we could have 6 programs for you. How are we going to deal with that? And so this really came more from the patients, less from the providers. They said, well, if it's 1 or 2, I want you to let me know about the 2 of them. And I want to make a decision about which one I would choose. And then you can see up there kind of this facilitated enrollment in the program that they would choose. But if they were eligible for 3 or more, one of the quotes that we got from our patients was, I want like a Cosmo quiz. And we're like, well, I mean, a Cosmo quiz. Well, do I like to be in groups? Do I like online? And so I get to click through these things and use that to limit the 3 or more down to 1 or 2. that are going to be the best fit for me. And then after doing that, they also would like some facilitated enrollment into the program. So this is something that, again, like this might seem pretty straightforward to folks, but at the end of the day, we now have a product that we can move forward, or a strategy to improve the reach of these things, that is going to be amenable both to the patient population as well as to the providers. And so that's where we're at working on this one right now. The other thing that they liked is this idea of a community-wide. Just get the word out. Get the word out on all your programs. Get it in the grocery store. Get it all over the place. Get QR codes, all that kind of stuff. And so, again, I won't go through all of the things that we shared with them, but we did find a couple of community-wide campaigns that were relatively successful at helping to improve reach. And so with this one, it became a little bit different. The providers really liked this one because they were out of the loop. There wasn't much pressure on them. Patients felt like it was good, but they didn't really love that they would kind of have to be responding to things, because there's no proactive nature. Where the population health management, at least there's going to be one contact to you that you didn't necessarily ask for, but was cued because you could benefit from one of the programs. And then it would go to the idea that we had before, that kind of Cosmo type of program, and then we'd have the facilitated enrollment. So I probably could have left that one out. But what we ended up doing at the end is we did we really tried to get a little bit at what would be the mechanisms. Remember, we talked about context, strategies, mechanisms, outcomes. So with this one, we're thinking about what are the mechanisms of improved reach. And we really think about acceptability, appropriateness, and feasibility of the two different strategies. And the thing I wanted to point out here was to show you that in general, patients found everything a little bit better, right? Like when compared to providers. They found everything a little bit more feasible. They found everything a little bit more appropriate, and everything a little bit more acceptable. And when we talked about with the patients, you can see here the one they really liked from an acceptability, appropriateness, and feasibility standpoint was if you combine the two. Now, we're in the process of figuring out, how do we make this happen now with Utah Health, and with if we were going to do this type of community-wide approach. And so as you can see here, I got back to our who makes decisions idea. And for this one, again, our design that I just walked you through was a collaboration. We decided on what we would do. But now we end up at a place where we've got this adoption. So we've got these tools that we want to use, and who makes decisions on that. And the nice thing is that one of the partners in that integrated research practice partnership is the chief wellness officer, who is one of the people who gets to contribute to that decision. But she'll need to work with the internal IT folks and the people that have the queues for the electronic health record to be able to work things into the process. And one of the things I noted down here, that it really ends up moving at the speed of the clinical team now, right? Like, I could be really excited to do a research study, but I need to be patient, right? And sometimes that happens when we do these types of integration and you're really doing practice partnership, so that the relationships need to be long-term, and you're thinking about it over a longer term and knowing that everything doesn't happen just like that. Okay. Let me see here. I am 8 minutes and on slide 23 of 45. What do you guys think? What do you think? We can really crank into it. I wanted to give you a little bit more sense. Now, I wanted to throw that one out there because I always hate giving a talk and not sharing something that's right on the kind of the front edge of what we're doing, which is what I just talked through. The next thing I'm going to talk through is a much longer term partnership that I've had that included, again, you can see the makeup of this integrated research practice partnership, but it's really a little bit, I was jumping ahead. This one is entirely clinically focused. And this one I was going to give you a full kind of example of how we walk through integrated research practice partnerships. Again, this is one of those things that's the wonderful holy grail where we have a pull from a system. So you can see here the prioritization that we start with our partners is, what is the need? What's the pain point that you're experiencing? And here you can see that 68% of the patients that chronic care coordinators who were at Carillion Clinic in Virginia, we're seeing had a BMI that was greater than 25. So that put them in the overweight or obese category. And they often were asking their nurse care coordinators about weight loss. Right? So how do we do this better? The downside is the nurses had some handouts and no training. Right? They had some handouts they could give people, but they really hadn't had training on behavior change. They hadn't had training on how we do evidence-based weight loss, because that's important stuff. We don't want to get people trying to lose weight with unhealthy tactics. And so the other thing that was really exciting here is that the leadership, or the decision makers in this partnership, really wanted a systematic solution. They didn't want to just have kind of one-off things. And so at the same time, remember, I'm going to take you on the way back machine to tell you that I said I have a dual aim. We want to have an impact while we're doing things with folks. We also want to advance science. So we want to come up with what some research questions are as we do this prioritization. And you can see what we came up with here is what's the best way to increase evidence-based weight management through chronic care coordinators. How feasible is it? And then can we use some adaptation of something that already exists so we don't have to create something brand new? So our next thing that we did was our strategy selection. And if you remember, we start with an intervention. We started with the diabetes prevention lifestyle intervention, which has shown efficacy. This was before we knew that it worked better for some groups than other groups, but that's where we started. And then we also picked an implementation strategy. And we used something that's called a consultee-centered approach, which is just such terrible jargon. Basically what it meant is that we used an approach where we put the care coordinators at the center of the process and said, how can we help you deal with weight management for your patients? And so from there, we build all of our training around the needs that they identify. And then we did adaptations, which I won't go through in a lot of detail. You can kind of read the bullet points up on the top. But we adapted both the DPP materials so that the nurse care coordinators could use them one-on-one visits. They could use it by telephone. They could do all that kind of stuff. And then we also adapted the implementation strategy to fit within the regular meetings that chronic care coordinators already had. So we tried to make sure it was a time-neutral activity for them. In this one, we did what we called an integration trial, and it was, again, I won't go into the lingo there, but basically what we did is we had, in the healthcare area, we had 3 different regions. One region where was the central hub, where they always tried new things out. The administrators asked that we not do our stuff there first and use that as more of a comparison group and see how we could do in some of the other districts. And so we selected one district. It wasn't randomly assigned. Then we did the strategy with that district and then followed the other 2 districts. And you can see what we did is all 3 of the districts got a continuing medical education session that was, I think it was a half day, maybe it was, received 1 2-hour CME session, and they got all the materials, they got some role-playing opportunities, all that kind of stuff. The other group, you can see we integrated our approach to basically a goal-setting feedback loop. How are we going to get people involved in weight management? How many folks do we want to reach? And really, again, it came back to reach. They wanted to use reach as a goal here. And we created action plans. So you can see up there, what you see right now is just one of the nurse care coordinators' action plans. And you can see they have, I'd like to recruit 2 people over the next week, 3 people over the next however many, I can't remember how many months it was, but basically they set goals for short and medium term. And then we created an overall goal for the region itself, and you can see the goal was to get 157 patients through weight management within the first year. So that's what they set their goal for. If you can't, I know you can't read really closely, but in this action plan, we also have them identify what would be the barriers to achieve your goals, and then what are some resources and strategies that we could peer share, peer learn together to be able to overcome that. And so I'm going to go through this relatively quickly. These are the re-aim outcomes, as you guys remember. And the really neat thing here is we got 70% of the nurse care coordinators to adopt the new weight management intervention in the first year. That was significantly more than 60% that adopted it in the group that didn't get our goal-setting feedback loop strategy. You can see the thing where we found the biggest impact is all of them sustained it a year after we were done the project. So all of those nurses were still delivering the intervention, where of the 60% that were in the other conditions, only about half of them were still delivering it. The other things that are pretty exciting, we had a lot of variability in reach. This wasn't statistically significant, but you can see per nurse care coordinator, we had almost 25 patients per coordinator in the group that had the goal-setting feedback loop strategy, and much less in the basically standard care type of group. And then you can see that we also had better effectiveness. So even though they were focused on reach, they ended up having better outcomes with their participants. And one of the really curious things that we found with this particular study was that we didn't see much difference in implementation fidelity. And we would have thought that when you have better effectiveness, that it means that they were doing a better job delivering the intervention with some level of fidelity. And in some of our qualitative work, what we found was that the nurses that were in the training program actually would kind of change things around based upon what the particular patient needed at a given point in time. And so we started thinking about this idea of not only fidelity, but also competence and understanding what the underlying principles were that made the intervention work. And then if you knew that, you didn't necessarily have to have any higher fidelity, but you could still have better outcomes. Okay, so the really exciting thing about this, again, is when we got down to the decision making, this was, the numbers aren't quite as exciting as Watt, Kansas, but really the outcome was just as exciting. You can see that there was a decision made to maintain the implementation and continue to scale up across the clinics. And in fact, the process that we used to help improve that implementation and reach was then taken to scale across all regions. And so they hired someone to do that. And so they put in a new position. And then they also made changes to their electronic health record to help facilitate implementation. So there's a whole bunch of changes that happened. And again, mostly because of that interaction between research and practice partners. Okay, I'm going to kind of move through this next one. I'm just going to let you enjoy the graphics for a moment. One thing I talked to you a little bit about before is I'm really interested, this is more of the sciencey piece, right? Like, what's the strategy we're using? What's the mechanism by which we're achieving our outcome? And so you can look up here. This is a weight loss program that we developed initially for workplace implementation. And again, we had partners that were from employer group, insurer, as well as commercial partners that could ultimately take this type of program and sustain it. And so again, I'm going to just kind of walk through really quickly and show you, when you, again, the idea here that I want to highlight is working together with different constituencies allows us to create different types of interventions. And with this particular intervention, one of the things that we did was we used a behavioral economics approach. And what that basically means is we wanted to have a little bit of a nudge for people that would move them from the point where they really found the more attractive, less healthful behaviors. And we wanted to try and nudge them to what initially are less attractive or less enjoyable, but more healthful behaviors. And so in this particular study, our main thing that we looked at was, what if we paid people to lose weight? And so now you might think, hey, is that really feasible? Is it something that's ethical? Are you moving people into extrinsic motivation? And then once that goes away, well, we thought about all of that. And again, we did a lot of work with our partners at the beginning and came up with a fairly simple plan. And basically what we said, hey, we're going to pay you $1 per % weight loss you lose every quarter. And if you lose more weight, we'll pay you that more amount of money. And so if you start to think about what's a clinically meaningful weight loss, for those who know, it's 5%, right? So if someone joins a program, they lose a clinically meaningful amount of weight in the first quarter. At the end of that quarter, we'll pay them $1 per % per month. They'd get $15. So it's really a very low investment. And in fact, the overall cost of those incentives was about 10% of the overall program, which is much lower than a typical marketing program would be for a weight loss program taken to scale in the way that we did. And so what we found with this one was our primary outcome, again, was reach. And so you can see here the green bars represent the workplaces that had the incentive. And in those workplaces, we got almost 40% of those that were eligible, or 40% of those that were eligible to engage in the programs, where it was about 25-30% for those that didn't have that incentive. And the other thing that we found was that it was more successful at recruiting people that were from underrepresented groups. Okay, and so I'm going to skip through our effectiveness, adoption, implementation, but let me tell you, it worked pretty well. We then took this same thing to scale in communities. And so for this one, we had 40,000 people that ended up participating. This one I had done in Colorado. And I'm not going to tell you a ton about all the details on it, but we ended up showing that it was relatively effective in helping community members lose weight. But one thing that we found that was really exciting to us was it also was quite successful when we think about it from an equity perspective. And so what we found was for African Americans that participated, you can see there was about 3,000 in this particular study, and that was about 8% of the overall population that participated. But in the region we did the study, the census data was only about 2% African Americans. So we got 4 times the representation from that population. So you can see 4 to 1 more likely to participate. And the really exciting thing was that 35% of them lost 5% of their body weight compared to 19% of the rest of the program participants. So this was kind of our first one where we're like, yes, we finally are really close. We have something that will reach a population that experiences disparities in obesity to a better degree than other things, and it also is more effective for that particular population. And then when you kind of move forward through that, they were African American participants were also more likely to sustain that weight loss for up to a year. And then the cost, because more people, and it was a low incremental cost for people to engage in this, it was a community program, but a digital community program, it was much less expensive to get African American participants to a 5% weight loss, which also, it's always nice when you can talk about that financial benefit to the work that you're doing as well. So this one is another one that we're knee-deep in continuing this partnership. We've expanded here, and you can see that we've got a whole bunch of different partners now in addition to the original ones. And we've been working primarily in North Omaha, which is an area in the United States that one of many places that is historically redlined, which means that basically the black population was pushed into areas of the city that are less well developed, less resources, more difficult to obtain mortgages, all that kind of stuff. And so it's predominantly black and is a community that has highly prioritized obesity. And so with that group, we've kind of scaled up some of the things that we've done there, but they also highlighted the need that even though we had shown this in Colorado and with the population there, they really wanted to look at the intervention itself and kick the tires themselves and say, is this really relevant for people in our community? And so you can see we ended up developing new work groups within that community. We have a steering committee, an adaptation work group, and then a work group that's focused on policy systems and environmental change within the community, that all with the idea that by doing these things, we can have an adaptation that will further improve the reach, effectiveness, and retention of the program. And then the policy system environmental change group believe that if we can make changes to the community environment, that also should lead to improvements in reach, community support, and sustainability for the program. And this one, we're not very far along. We're just getting ready to start a pilot where we're testing our newly adapted intervention within North Omaha to the original intervention that we did. But this one was really kind of fun because we basically did a 3-month process where we met with community members every 2 weeks, and we all did the program together. And we reported out, and we, of course, had a bunch of different things that completely overwhelmed them, the research tools we used to try and get feedback from them. But the really fun thing was we just got together and talked. What types of things would you like to see? And they ended up really just identifying about 8 different things that were important to them. So you can see up here, they were obviously nothing, this is just kind of like saying the sky is blue. It'd be really nice if there was more pictures of people like us that were in the materials, and this is, again, a digital health intervention. They also would like to see more culturally tailored meal plans, and so we hired a registered dietitian that was from the African American community in North Omaha, and 365 days, we got all new meal plans that are focused specifically on the diet and the types of meals that are eaten in Omaha, Nebraska by that community. We also found that they wanted additional kind of human support to our technology. So we've developed a health ambassadors program, and that's something we're testing out to look at how they can improve reach. But then once people are in, one thing that I didn't mention earlier is that digital health interventions have a really high attrition rate. So people start them and then drop out of them really quickly. And so the idea of the health ambassador was to help people enroll, but then also have some access to the information so that we could pinpoint and reach out to people when they were either declining in engagement or maybe disengaged from the program. They also wanted more peer support. And again, for those who have studied kind of cultural components and concepts, collectivity versus individuality, Black community collectivity is higher than it is in the white community. And so, again, it wasn't a huge surprise to us that they wanted additional tools built in that they could interact with one another more readily. And then there were some things that were just, your usual types of things. Hey, it'd be fun to have badges. It'd be fun to, be able to have on-demand trainings and things that are less about the culture and more about digital health equity, making sure that folks understand the tools. So this project, we're just kind of moving forward. We're in the midst of developing our ambassador workflow, and like I said, we're hoping to start recruitment for this one in the next couple of weeks. So I thought I'd kind of finish up just with why do I think that these types of partnerships work? And I think we have enough data now that, I didn't go really data heavy on this. Hopefully I didn't go in too much detail or not enough detail. But we really think it's this idea of integration of evidence, and evidence from a scientific perspective as well as from a community or practice perspective, that by doing that, we're able to get the tacit knowledge that that's a little sticky, that's hard for people to communicate. But when you're doing partnerships and creating and co-production of tools and strategies, those things get integrated even without that articulation. The second thing is, I'm a big believer in this kind of vertical and horizontal systems approach. And, to put that into more lay language, it's like, you need a decision maker and a doer. Right? You need that vertical system within organizations, but then you also need across organizations who are key constituents in either the reach of the intervention or the organizations that provide services to the folks that you would like to benefit from your interventions. Are they just supporting agencies that might be able to identify support for finances and those types of things? So this idea of making sure you have that vertical nature within your partnerships, as well as having the key constituents organizationally, horizontally across your community. And then, the other thing that we think a lot about is this idea of form versus function. Do we have to take you're doing knowledge mobilization and you say, this is the intervention that works, do you have to do that intervention exactly how it is? Or could you completely change the form of it, but remember what the principles were that was based on, and create a new form that still adheres to those principles? And our belief, and I think we have enough studies now to show, that when you focus on the principles and you let the form fit the particular context, you still get really good outcomes. And so I think that's another thing that we've learned quite a bit. The other thing that I think is relatively clear from the work that we've done is that when you do these partnership approaches, you have a much better opportunity for interventions that go to scale and can be sustained. Right? So our community program that I showed you there, that was sustained for about 8 years in Colorado, and then financials changes and that kind of stuff, and the primary supporter of it stops supporting. But when you build things that are in an infrastructure that is sustainable, the likelihood that it's going to be sustainable is much better. And I'll just do not nearly enough time for all of the people that work on different projects. I think I might even have some of my good collaborators up here on projects that I didn't present because I was reorganizing slides right up until I came here. But it's so wonderful to have such a great opportunity to work with so many great people. And again, there's too many up there for me to list. Then disclosures, this is just the places that our projects are currently receiving funding for. And so I don't think there's anything that's a conflict up there. No, I don't think that anybody's paying me to say anything specific here. And with that, I'll open it up for questions, comments, or smart remarks.